Hi, so welcome everyone. If you like tonight's talk and you want more information, you can feel free to get in touch with me. I'm Stacy Loeb, and I also host a radio show on Dr. Radio, Sirius XM 81. So if anyone has XM radio and wants more information, my next show on prostate cancer is October 24th. I'll be having Dr. Catalona, who's the founder of PSA Screening, on, as well as Coach Jim Boeheim from Syracuse men's basketball and the Olympic team, who's a prostate cancer survivor, to talk about his experiences. So you can feel free to listen to that as well. So by way of background, what is the prostate? Well, it's an organ that's only found in men, and it's in a very important location because it's near a lot of the other organs in the pelvis, including the bladder and the bowel. The prostate also makes this substance called PSA, which we'll talk about in a minute. Prostate cancer is a very important problem because it affects about 1 in every 6 men during their lifetime, and it is still the number 2 cause of cancer death in the United States. Prostate-specific antigen is this substance that is made by the prostate, and it is higher with prostate disease, whether that's enlargement of the prostate because there's just more prostate there making more PSA, or in prostate cancer. The levels of PSA also do correlate with the aggressiveness of prostate cancer if it's present, so it's used for risk stratification. PSA, as I mentioned, can also be elevated in things like infection and inflammation, but it is our main screening test that's used for prostate cancer. Prostate cancer usually does not cause any symptoms at an early stage, so this is the way that we find prostate cancer early. Before we had PSA, because there were really no symptoms of early prostate cancer, most men presented with metastatic prostate cancer. These are pictures of bone scans where there's a lot of prostate cancer that has already spread to the bone. It's rare that we see anything like this anymore because now the majority of cases are diagnosed much earlier through screening. Screening has also led to a vast decline in prostate cancer mortality in this country. The red arrow shows when PSA was introduced, and since that time, there's been more than a 40% reduction in prostate cancer mortality. There have been some mathematical models to figure out what caused this reduction in mortality, and it's estimated that about 40 to 70% is due to screening. So why is PSA screening so controversial? This is one of the issues I wanted to talk about. Probably you've followed some of the debate in the New York Times. There's many different professional guidelines regarding PSA screening, not all of which are the same, so this can be very confusing. The first set of guidelines are from the American Cancer Society, the American Urological Association, and the National Comprehensive Cancer Network. These guidelines all say that men should be informed about the risks and benefits of screening, and they all have a common feature where screening can be offered starting at age 40 to men who are interested in order to get a baseline value, which is something that I think is very valuable. The next set of groups thinks that there's insufficient evidence to recommend routine screening. So what this means isn't that they're against it, but just that one recommendation can't fit the entire population, so we need to make more of an individual decision about each patient with the patient, but on a population level, we can't be sure. ASCO, the American Society of Clinical Oncology, recently came out with new recommendations about PSA screening. They say that PSA screening should be discussed with men who have at least a 10-year life expectancy, but should not be given to men who do not have at least a 10-year life expectancy. And finally, the recommendation that got the most controversy this year was the U.S. Preventive Services Task Force, which was the only one of the group who recommends completely against prostate cancer screening. The American Urological Association, which is the main organization for our field, was very against these recommendations. They felt that the Preventive Services Task Force does a great disservice to American men and may cause more harm than good by recommending against screening. They also felt that it was inappropriate to issue a blanket statement like this because most of the studies didn't include a lot of African American men or men with a family history of prostate cancer, so making a vast recommendation that might affect some of these higher risk populations could be harmful. And finally, the AUA felt that the Preventive Services Task Force had overstated the harms and underestimated the benefits of prostate cancer testing. So what are the benefits of prostate cancer screening? Well, there have been 3 recent randomized trials that have looked at the effects of screening. The first one is the prostate, lung, colorectal, and ovarian cancer screening trial, which is known as the PLCO. This one was performed in the United States and included about 76,000 men, where they actually randomly assign men either to undergo screening or just undergo usual care. The problem with this is that the United States screening is so widespread that most men who were assigned to usual care ended up getting screening also. In fact, more than half of them. So really, it just compared organized screening to usual care, which usually involves screening. And as is not surprising, they did not find any difference in prostate cancer mortality between the 2 groups. The European trial, on the other hand, was about twice as large. It had 162,000 men who were also randomized either to be screened or not to be screened. In this case, it was a very different situation because Europe did not have much PSA screening in the background. So it's really more of a pure trial to look at the efficacy of screening. And they found at 11 years that screening significantly reduced metastatic disease and reduced death by 21%. And that's including people who didn't follow through with screening like they were supposed to in the trial. So if you corrected for all of that, the reduction in mortality actually went up to 29%. So a pretty significant benefit for prostate cancer screening in this trial. The last one is the Swedish randomized trial of prostate cancer screening in Gothenburg, Sweden. And this one had 20,000 men, so it was quite a bit smaller than the other trials, and they did collaborate some with the rest of the European group. But this did include the youngest age men. It went down to age 50 in this trial, and they had the least amount of PSA screening going on in the population. So once again, they were really able to compare what happened with men who did get screened to men who really weren't getting screened. It also had the longest follow-up. It takes many years for prostate cancer deaths to occur, which is good news for those who have prostate cancer. And at 14 years, screening in this case reduced metastatic disease and led to a 44% reduction in prostate cancer mortality. In this trial, they reported that 12 men needed to be diagnosed with prostate cancer, not necessarily treated, but diagnosed in order to save a life at 14 years. Just as a comparison for that, about 10 women need to be undergo a mammogram in order to save one life from breast cancer at 10 years. So why is it so controversial in light of this evidence that I've just shown you from some very good studies showing that it decreases death rates? Well, one is the problem that PSA screening is not specific for just prostate cancer, and in fact, PSA can be elevated in multiple benign conditions. So this includes enlargement of the prostate, where there's more prostate there that's just making more PSA. Also included are urinary tract infections and urinary retention. Each of these things can cause false elevations. So some solutions to this problem are to take a good history of the patients before initiating screening, not performing screening during an infection or during urinary retention. We also have some newer ways to do screening. One of the big focuses of my research is on PSA kinetics, or looking at the change in PSA over time as a way to predict the likelihood that life-threatening prostate cancer is present. And finally, combining tools together. We used to just base things on one PSA number, and now more and more we use all kinds of information together to give someone a much more personalized risk estimate of how likely prostate cancer is. And this includes their age, their comorbidities, how big the prostate is, whether they have a family history, race, and their prior biopsy history. Because PSA is the single most important predictor of prostate cancer, but the risk is modified a lot by these other variables, and it's important to consider many things together. Another reason that screening is criticized is that an abnormal screening test in the form of the PSA blood test then leads to an invasive diagnostic test or the prostate biopsy. Our group looked at this recently, the complications of prostate biopsy, and we did find that the infection rates are increasing. That's what this red line shows. And this is due to more antibiotic resistance out in the population. So there is some concern about prostate biopsies having more complications than in the past. But this is not insurmountable. There are many ways that we can reduce the risks of prostate biopsy. First of all, careful patient selection. It's also important to discuss the risk factors for infection, such as diabetes, foreign travel, and recent antibiotics. The antibiotics that are given for the biopsy can be tailored accordingly. It's also important to consider that antibiotic resistance is different in different parts of the world. Here at NYU, we have an antibiotic stewardship program where we know exactly what the patterns are in our institution, and most places have this, so the antibiotics that are given for the biopsy can be adjusted accordingly. Also, just to counsel patients about the risk of infection so they know what to look for and are less likely to get into serious trouble. And finally, there's a lot of research into new ways to make biopsy safer. One thing that's being investigated is whether we should actually perform cultures before the biopsy and then give targeted prophylaxis. Dr. Taneja will also be talking more about imaging, and there's some new biopsy techniques that are in the pipeline, and all of these things together might help to reduce the risks of biopsy. But overall, the risk of a serious complication from the biopsy are very low and much lower compared to the risk of morbidity and mortality from prostate cancer. So in appropriate candidates, fear of complications with the biopsy should not preclude the procedure from being done. Another limitation of PSA screening is the possibility for overdiagnosis and overtreatment of clinically insignificant prostate cancer. So one issue is that not all prostate cancers are life-threatening. In fact, some would have never been found during the person's lifetime without screening. And so treating these cancers may be more than is necessary, and all forms of prostate cancer treatment can have potential side effects like erectile dysfunction and incontinence. So what are some solutions so that we can find the cancers that are dangerous and not find the cancers that are not dangerous? Some of the solutions we've talked about earlier. There are some variations on the PSA measurement that are now available that are more specific, which means they hone in more on the life-threatening cancers. Free PSA, some of you may have heard of. It's one of the types of PSA. PSA can either circulate in the bloodstream bound to proteins or in a free form. The more that's in the free form, the better. There is a new test that was just FDA approved called the Prostate Health Index, which takes PSA, free PSA, and another value all in the same blood test. And it is more specific at showing which cancers are dangerous than regular PSA. I mentioned before PSA velocity, or how rapidly the PSA is rising. We've shown that that's associated with how likely a man is to have life-threatening prostate cancer. There's many new markers now than what we had in the past. Some of these you may have heard of. The PCA3 test is a urine test that is now FDA approved for men who have had a negative biopsy and are going to undergo another biopsy to predict the likelihood that cancer is present. And finally, as I mentioned earlier, this multivariable approach, or considering many factors together. There's no reason that the PSA needs to be used in isolation, and considering all of the other risk variables along with it can really help to create a more personalized profile. This is the subject of Dr. Tanasia's talk in a few minutes, but there's also significant improvements in imaging. MRI has really come a tremendous way in the past few years and has been shown to correlate with the grade and the amount of prostate cancer that's present. So I'll leave that to him, but there also may be a lot of help in this regard from MRI. Another way to try to reduce the problem of treating cancers that are insignificant is just by decreasing the morbidity of treatment. 20 years ago, there was only open prostatectomy. The nerve-sparing prostatectomy came along 30 years ago, which led to a significant reduction in side effects. Robotic surgery has come along in the past 2 decades and has really taken a lot of the forefront in the management surgically these days. Also, there's a lot of emphasis now on not treating everybody. It is possible, once you find out you have a diagnosis, if it's low risk, to just watch the disease over time. This is a quote from another urologist that I really love, which is, treatment or non-treatment decisions can be made once a cancer is found, but not knowing about it in the first place surely burns bridges. This really sums up my attitude regarding screening and treatment of prostate cancer, which is that for me, I would like to know all of the information in front of me, so I think that screening is useful, and what somebody then decides to do with that information, screening is the way that we find the aggressive cancers that will cause morbidity and mortality, but it also allows us to make a risk stratification, and not everybody has to be treated. So regarding the screening controversy, the benefits, which I do think outweigh the harms, are reducing metastatic disease or spread of prostate cancer. It does save lives because it decreases the amount of deaths from prostate cancer. And as I mentioned, if you look at 14 years down the road, only 12 men needed to be diagnosed to save a life, which really isn't very many. The harms that we talked about, unnecessary biopsies, because sometimes the PSA is elevated for other reasons, but we really can help sort that out more with some of the new tests that we have. And then the overdiagnosis and overtreatment, which we can try to solve by not treating everybody who's diagnosed and figuring out who has a dangerous tumor and who doesn't. So this schematic summarizes how I think that we can maximize the benefits of screening and minimize the harms at every step along the way. The first step being better patient selection for screening. So as I mentioned with the professional guidelines, we should focus on men who have at least a 10-year life expectancy. And if they do, we do start to see gains in survival beyond the 10 to 15-year mark, and screening can be helpful. Also, avoiding PSA tests during things like infection or retention, where the PSA is clearly going to be elevated for other reasons and the test will not be informative. The next step is better screening, which we can accomplish using more personalized protocols, using the rate of change in PSA over time, taking into consideration multivariables and not just the PSA test, as well as new biomarkers and imaging. Once a diagnosis is made, we can make a change by having better patient selection for aggressive treatment, where aggressive treatment is reserved for people with significant tumors and a long life expectancy, and we increase the amount of active surveillance and watchful waiting for men with low-risk disease or with a lot of other medical problems. And finally, better treatment. And here and elsewhere, we continue to improve the quality of both surgery and other types of prostate cancer treatments, because if treatment had no side effects, then certainly there would be less concern about overdiagnosis and overtreatment. So I think that right now we're on the 30-yard line. We've come a long way, but there's no reason that we're going to turn around and run back to the end zone. So what we need to do is continue to move things forward, and I think we can be successful against prostate cancer. Thank you.